All right, good afternoon. So we'll start with this session with superficial renal reflux disease and venous ulcerations. These are my disclosures. Varicose vein or venous insufficiency is very prevalent. It affects about 24 million Americans in the country yearly. And approximately 20% of this patient can go to develop irreversible skin damage with chronic venous insufficiency. And what you really want to prevent is venostasis ulceration, which is very debilitating for the patient, and it affects 2 to 3% of the patients. This is a CF classification, C2 symptomatic patients when you start treating, and this is what you want to prevent with chronic venous insufficiency and irreversible skin damage. I hope nobody's doing this in the 2022. This is vein stripping, very invasive, and we stopped doing this 20 years ago. The two major therapy that we're doing is thermal therapy. I'm going to differentiate between thermal and non-thermal. Thermal is laser and radiofrequency ablation, where you actually use energy to shut the vein down. You basically burn the vein. You shut the vein down by burning them with anesthetic. The major issue with this is that you can have nerve issue with the sural nerve, most likely from the SSP ablations, and the GSP is the saphenous nerve. If you look at RFA with laser, they're very compatible, very efficacious, closure rate in the high 90s. However, there's a little bit, the pain score is a little bit better on the radiofrequency ablation, and that's the treatment that a lot of us use compared to laser. Now going into the non-thermal, this is the MOCA therapy. This is a catheter that rotates really fast at 3,600 RPM, makes the vein really small, and they inject sclerotherapy, foam sclerotherapy, and this is the way you shut the vein down without using energy or without burning the vein. If you compare it to RFA, very good closure rate in the high 90s. And outside comparing with RFA, with this non-thermal therapy has less pain and the return to normal activity at an earlier day compared to the thermal therapies. Venous seal is another non-thermal. This is very simple idea. They took crazy glue and you injecting crazy glue, basically modify crazy glue into the patient. You hold pressure so there's no, your risk of DVT is lower, and you basically want to make the vein like a pancake, and you're basically injecting crazy glue, and you try to shut it down. Compared to RFA, again, very good closure rates. However, with a lot of this non-thermal therapy, you have to be careful, because when you treat veins that are quite large in its diameter, the risk of thrombophlebitis is a little bit higher, 15% in this study. So I tend to, really select my patient with non-thermal therapy, patients that have a smaller vein size or less than 1.2. 1.2 is my cutoff. And if not, I use a thermal therapy. With Venous, you can use this whole system, this whole catheter system with a gun to deliver a glue, but we have moved on to actually injecting directly into perforators or through a catheter-based therapy if you have shorter segments. Very thin is another very widely used non-thermal therapy. This is foam sclerotherapy, but it comes from this catheter. It's mixed with oxygen, and what it does, it makes the foam sclerotherapy very compound. The dwell time in the vein is twice as much as the foam sclerotherapy that you can make as a physician. And looking at this Venous 2 study, the closure rate is in the 70s compared to radiofrequency ablation or laser. The efficacy is much lower, but we have a lot of success in recurrence vein that are not bigger than 1 centimeter. This procedure works fairly well. This is looking at the CMS beneficiary data. If you look at what we are doing in this country in 2020, about 50% of the patients are being treated with non-thermal versus thermal therapy. So you can see the trend that we have developed here is that what we used to do, laser and ablations, are being replaced by this non-thermal therapy. And compared to RFA and laser, a lot more physicians are utilizing RFA procedures. If you look at this patient, this is a patient that the GSP is less than, or the gray saphenous vein is less than 8 millimeters. This is a great procedure for non-thermal therapy with great result. If the vein is a little bit bigger, such as this patient, I tend to use thermal therapy. And we get good results. Again, my cutoff for non-thermal is 1.2. If the vein is really big, such as this patient, bigger than this patient, varicocele measuring about 2 centimeters, I tend to do a staphyloidectomy first, so a concomitant staphyloidectomy with truncal ablation, because if not, you could get a severe phlebitic reaction from this. Sclerotherapy is very helpful in your patients, especially because a lot of patients that have varicose vein, they want cosmetic therapy. You can see we're injecting it, and the results are pretty fantastic after the procedure. They do develop a lot of inflammation, and the vein can take up to 3 months to go away, but it's a great procedure to have it in your practice. Staphyloidectomy is really important because even though you do truncal ablation, truncal GSP or SSP, your veins might not go away. This is a very simple procedure that anybody can do. Use a small 18-gauge needle. We don't do incision. There's no sewing. You go in and you basically use small clamps or hooks to get the vein out. So very simple procedure, and then I put a glue at the end to basically shut it down. So a very simple procedure that you don't have to be a surgeon to do this procedure. So these are two very important procedures that should be in your practice. So going into venous ulceration, what are the treatment modalities with venous ulceration? So if you look at the pathogenesis, it's unclear what causes venous ulceration, but the most important thing is venous hypertension. Without venous hypertension, you wouldn't lead to this. So we have to get rid of the venous hypertension. So there's two level 1 evidence trials now. The ESCA study is actually quite old. It's 2004 from Lancet. It shows that if you do surgical correction, and this was open surgery, it was not the non-invasive therapy, is that recurrence of venous ulceration decreases tremendously compared to compression alone. Now we have the EVERA study published in 2018 that actually shows that if you do a truncal vein correction, or you do ablation, you do foam sclerotherapy, whatever therapy it is that this is a level 1 evidence trial showing that early intervention within 2 weeks, the ulcer heals much faster than doing ablation by itself. So treatment of venous ulceration is, we are really going to the non-thermal because the ulcers are really near the ankle, near the median malleolus, where there's not a lot of tissue there. So it's very hard to treat this with thermotherapy. And if you look at this meta-analysis, nerve injury is actually quite rare, and some of the studies show 7% nerve injury from procedure, as well as skin burns, because the ulceration is really close. This is one of my cases that I'm getting retrograde axis in order to avoid nerve injury. So what are the things that we have done at Mount Sinai is that we have done this non-thermal therapy with MOCA therapy, getting into perforator, and I'm really trying to avoid that nerve injury. This is one of my patients had ulceration for 5 years, and a couple of MOCA therapy, 5 months, this was completely healed. This was published 2 years ago in the Journal of Vascular Surgery. Our results compared to thermotherapy shows that the ulcer healing rate is twice as fast when you use non-thermal therapy. We're doing this same approach with Venous. We're doing direct injection into perforator. You can see direct injection of Venous glue. You can see the vein is patent there with flow after glue injection. That's completely close, and we have achieved very, very good closure rate with this. We are on the process of writing this, but MedStar bid us, and they looked at glue versus RFA, and with glue or with Venous, the closure rate is much faster. And we're looking at this with Baratina as well. So conclusion, thermal methods are safe and effective in treating superficial venous reflux. Non-thermal therapy are very promising. Insurance coverage has been some of the major issues, especially in MOCA, because not all insurance are covering it. Non-thermal therapy tend to be more effective, I think, in treating venous ulceration, and I think that's going to be the future in treating these patients. And don't forget about sclerotherapy and microphlebectomy are important therapies in the treatment of superficial venous reflux. Thank you.